Absolutely. I'm going to fiddle with the audio, make sure I can hear you a little bit better. Turn it up. There we go. Should work. Okay.
Got to clue everybody in that just tripped over this live stream. We're going to throw up a EEG recording. You were going to throw some commentary in there. And then when people get a little bit more into it, we'll answer some questions later. And then tomorrow when I meet with Jay Gunkelman, the man who's read over 500,000 brain scans, we're going to show it to him live, raw. He's never seen it before. And we're going to have him expound on what we talk about today.
Yeah.
That sound about right, Joshua?
It does. And it sounds like fun. We get to see a little bit more of an amateur process it and then the master. And, I have these anonymized, but the reality is that having done these cases, I'm going to remember them just by looking at the brainwaves, which is so weird. Like you have a hard time remembering faces. You have a hard time remembering names. But brainwaves, that'll take you back, man. You'll remember. You'll remember brainwaves.
That's a hell of a thumbprint, huh?
It's crazy. It's just bizarre how your brain will just retain that information. I think it's kind of a learned thing. Like, I don't think everybody, can do that. But after years and years of looking at brain maps, you just kind of think about people that way. It's like, I can't remember their name. I can't remember why they're here. But as soon as I look at their brain waves, it's like, oh yeah, that's the person with this problem, with these symptoms. And, it's like you're looking at them and they just kind of like, that's kind of what orients you to who they are. And it's like, it's the window by which you make sense of them. And it's so weird because I don't think anybody else sees the world that way.
Yeah.
So, it's orienting information.
Hey, Saul.
Hello, everyone.
Saul, how you doing?
Good. How y'all doing?
Pretty good. I'm just kind of pulling up this anonymized case and making sure that everything's squared away. I think it's good to go. So, yeah.
Saul, how's the Northeast treating you?
Not too bad. You got warm and rainy weather today. Tomorrow will be freezing. New England at its best.
Don't like the weather, just wait a few minutes.
Exactly. And how are things out there in the warmer areas of the world?
In Chicago, we're beautiful. 80 degrees one day, 30 the next. We're fine. We love it. Good. So, Saul, we're going to throw up a EEG recording here and give it a gander. And when the crowd gets a little bit more energized, we'll answer some questions on there.
Okay.
Is that how you understand things, Saul?
Sure.
Sure.
I'll just roll with it. We'll see what happens.
Yeah. The brain bar.
Yeah, we generally like to look at brainwaves to orient ourselves to what's going on with the case. At least I do. And it feels incomplete if I haven't done that, It's like, I got to know.
And people just like to show you the pretty colors and pictures, but you want to see the lines, right?
Yeah, absolutely.
Yeah, definitely. I think that I almost quit the whole thing of brain mapping. I'd probably taken close to 10 QEG courses. And I couldn't even describe what the feeling was about it not being right. But it was just a large amount of not feeling right, that we were. Yeah. It was more like my spider sense was saying, no, this isn't right. This isn't right. This isn't right. And it wasn't like I wasn't getting some results. It was just, it didn't feel right. And I kept taking classes to see if I could fill that gap, and it never got filled. And then I met Jay, and I think it was like the first time Jay processed it in the raw data and was talking about what they were in the raw data, that it was like pretty quickly, it was like, this is the piece that my unconscious has been screaming at me for years. And it didn't take very long before I realized, no, I'm not going to quit. I'm not going to quit brain mapping, because I had access to things like infralow and infraslow, and I was getting good results with those things. And then brain mapping, when you're doing just these automated maps, it just felt like it was so full of blind spots. It was like, well, why are we doing this if it's so full of blind spots? I have these other protocols that, are, they have reasonable success rate when you're flying blind with them. So why do I want an assessment tool that doesn't have this phenomenal accuracy and this ability to predict experience? And not that I understood that that's what I was seeking. I just knew something wasn't right. It was an inarticulate bad feeling. But fast forward, something like 7 or 8 years, it's like, okay, Yeah, this is great. This is what we wanted. Just didn't know what it was that we wanted, but we got there.
Well, you want to throw something up, and we'll get some feedback from the crowd. Make sure everybody can see it. Well, let's see.
I think we're doing this. Oh, there we go.
Wait. Where'd you go, Joshua? I think you clicked yourself out.
Oh no.
There's us.
Oh,
Whoa.
well.
Whoa. Hey.
You have all sorts of good controls there.
When Joshua comes back, there he is.
There he is.
Oh, I'm sorry. I pushed share. I must have pushed the wrong button. So I think I want to share my screen. So
No sound.
Oh, 1 second.
I can hear him.
Oh, you can? No, I can't. That's
I'm there.
interesting.
Interesting.
'Cause I can
You
hear
can't hear
you,
me
but
at
I
all?
can't hear Joshua.
Okay, interesting. If I need to log out and log in again to try to get Saul, let me know. So if it's just Saul who can't hear me, it's probably just a glitch in me loading in again. Saul, you still can't hear me?
I think we're good. I think we have the whole screen up here.
Okay.
For the people in the room, if you can't see, please speak up. And
can Saul hear me?
So
Saul,
I may not be able to hear Joshua.
Okay. Let me log out and log back in. I just want to try to get Saul back in because I really want I want his thoughts on this.
Yeah,
it's not a complicated case. I think it's
I definitely can't.
You know. Okay, hold on.
Saul, it's me and you. It's me and you.
Okay. You I can hear.
Unfortunate for you.
Well, no. It's... Ignore the technical problems. Ignore the man behind the curtain.
There we go.
All right, Saul, can you hear me now?
Yep, still can't hear him. You know what, maybe I will pop out and pop in again.
Okay, that's a good choice. Yep.
Let me try to do that.
Hopefully we'll get him back here in a second.
So
okay, can you hear me now, Saul? You there? Do we got him? He can hear Pete, right? He can hear you, Pete, right?
Yeah, he can hear me.
Okay.
Yeah.
Yeah, that's interesting.
What the issue is.
Very unusual problem.
I think he's coming back in.
Let's give him, yeah. Seems like the most reasonable thing. If you can hear me, it's definitely not on my end. It's got to be just something goofy with
it's Saul's fault.
Oh, Saul's fault. Nah, it's more like the software. It just needs sometimes it needs a timeout. You got to turn it off to turn it on again. Every software is like that.
So now the question for everybody that's in the room, can they see the squiggly lines well enough? I'm sure somebody will speak up if they can't.
Well, and we're going to zoom in. We're looking at both of them. Here's a good thing. 50 microvolts, which is not, very far out. That's pretty zoomed in. You could almost look at it like 150 is, so we're not super zoomed out here. We're zoomed pretty far in. Can you hear me now, Saul?
I can, yeah.
Yes.
All right.
There you go.
All right.
Let's
There
go.
we go.
Have you tried turning it off and on again? Anyone who appreciates the IT crowd.
Yep.
Excellent. So I'm different than Jay in that I look at the eyes closed first. That was what my first mentor taught me, and I have a hard time deviating from it.
Yeah. No.
Hey, there we go.
There
We got Anthony.
Hi, thanks, guys.
Yeah, it's
Hey,
good to
Anthony.
see you.
Hey, how does the squigglies look? Is it should we get rid of the faces and just go to the screen?
Yeah, they may not.
I think
they may
it's kind of good.
All right.
I think you want the personalities.
So, yeah,
The reality is somebody on a phone can't read it no matter what they do. So
That's right. Yeah.
this is true. You might have to watch it at a later date. I don't know if they can zoom in on YouTube. I don't think you can. So, yeah, it's got to be something with a reasonable screen size. Squigglies require detail. Maybe on this case, you could probably, see it with lower resolution than other cases. It's not exactly a subtle case.
fair. Interesting.
Thoughts from the peanut gallery?
I'm still setting up here.
You're good. Take your time.
Hey, Chad. Chad says he can zoom in on the phone. Okay, good.
All right, excellent. That's great. That's great
good.
feedback. That's encouraging for other people who want to zoom in. We could pause every now and then. People can zoom in and see which channels. So to get some information, the top channels are generally oriented towards the front of the head. This is an average weight montage. As you go descending down, you're actually kind of alternating left and right and moving down on the head, moving more posterior towards the center of the head, and then eventually the posterior and occipits is the very back. So your last two channels are occipital 1, occipital 2, and your front two are FP1, FP2. So you're kind of right above the eyes on the first two and right on the back of the head on the back two. And just kind of alternating back and forth all the way down. So, the logic would dictate that the middle is exactly that. It's the middle of the head. So, so just for those who need some reference point, you kind of develop a skill where you can visualize where this is. Just over time, your brain kind of accepts and understands sort of the phase and field of where these frequencies are coming from, and sometimes even maybe where they're going a little bit. You can get used to just the awareness of the layout and what it means.
Chad says little CZ activity there.
Yeah.
Just a touch.
E3.
Yeah. It's a hormone driving behavior by the brain. It produces a hormone called orexin. And orexin is a vigilance compensation hormone. And it will make you feel alert when you are not alert. And it will also, unfortunately, rob you of your sleep onset time and your deep sleep and your REM sleep. It kind of reduces those as well. Now, when it's found really, really acutely only at CZ, that's kind of maybe the best way to articulate when it most applies. Because while we do have a fairly large driver at CZ, it's not exclusive to CZ like it would be in a true orexin hormone presentation. It's more diffused and broad, and that diffused and broad behavior is something else. So you can block the orexin hormone pretty safely without it being habit forming or dependency forming. And it's actually, there's medications for that. But even outside of medications, the kind of natural way to do that is actually chamomile. Chamomile is an orexin blocking agent.
That's excellent information, Josh. Thank you.
Yeah, it's kind of fun. And so people who have this, it's, again, sort of an over-arousal, mechanism. It can be blocked temporarily with chamomile tea and chamomile oil, but it's not actually the whole story, because that's not the only place that the beta is. If we zoom in a bit, we're in the eyes closed, which maybe needs to be said. So what do you usually look for in the eyes closed?
Alpha.
Yeah, and what do we not have?
There is no alpha.
There's no alpha. Yeah.
And
there
what's
is,
the power?
It's small, you have a
What's
little bit of alpha here and there.
there it is. There's some.
Tiny though, tiny.
But it's in weird places too. What's the power?
So for those who can't zoom in, which is probably even going to be some of us, the power is going to be up here, and we're sitting at 50 microvolts, so we're pretty zoomed in. We're getting irresponsibly close to this, so it's not like we're doing a bird's eye view at this case. So if we're talking phenotypes, Anthony, or I know that not everybody into this is really, really into phenotypes, but I know Anthony is. Did Anthony know what this is?
A low voltage fast?
Yeah, you got it. That's what it is. Yeah, you're right. Yeah, it's a low voltage fast. And you can kind of tell that just from the eyes closed, though maybe 1 in 100 will trick you, in that you'll go to the eyes open and they'll have a ton of alpha. It's very uncommon though. That would be more of a persistent alpha eyes open phenotype. That's not going to be a common thing you're going to discover when you go to the eyes open, though. It's going to be a super minority of cases where they only look like a low voltage fast and the eyes closed, and then you go to the eyes open and, bam, there's a ton of alpha, which is backwards from what you'd expect. So the eyes open generally looks a lot more like the eyes closed than not, except you have to filter out eye blinks and a little bit more muscle tension. But in general, they look a little more similar than they do different. So there's a lot we know about these cases. These cases are like really, really well researched. Let's see, he's got El Chatterino. The right hemisphere is tuned up a bit over the left. Yeah, we get a lot of funny stuff like that in low voltage fast cases. The alpha is really out of rhythm. I've heard some discussion about the fast content is actually alpha, just highly dysrhythmic. I don't know if that's true or not, but I suspect it probably is. And so both the symmetry and the speed is just going to be, kind of shot to hell. And it's not necessarily obvious what will stick around once we actually suppress the high beta and train up the alpha. You have to kind of reevaluate what you're looking at after the fact. It could be different. It could be a lot better. It could be that kind of lateral observation that El Chatterino mentioned could be much, much worse when you give some power, or it could be much, much better. I tend to be more like phenotype first and then details second, because you don't know it'll improve once you start moving the phenotype towards normal. All the small detail stuff might come along on their own, because you're seeing, sort of a lack of rhythmicity because there's aminobutyric acid receptor sites are essentially overgrown because of a gene 4 variant. That's what we know in these cases. It's a genetic finding that you inherit from parent to child about 72 to 92% of the time. And it's, again, specifically related to gene 4. And it is an overgrowth of the GABA receptors. And then you have this relative imbalance in GABA because there's an overgrowth in receptor sites. And that drives the dysrhythmia of the thalamocortical loop. So that's what we think we know. So it's a lot more than we know about other phenotypes.
Chad's got a few orders in here. He starts off with, y'all hear anything about kudzu extract being of use?
That sounds very familiar. Does anybody know what that is?
Kudzu extracting of what?
Kudzu.
Y'all hear anything about kudzu extract being of use? Chad, need a little more.
For Orexin?
Oh, I don't know. Someone who has, Google can search that. It rings a bell. It doesn't ring a bell with me. I know that with Orexin, there's 2 medications that are primarily only handed out by somnologists, which is a little bit surprising because I've been told that they're fairly safe sleep medications, a lot safer than the ones you can get from your GP. Because they're not known for being habit forming or even dependent oriented, which is awesome. But they don't, get handed out by normal doctors typically. And the only natural supplement I've heard of that's an orexin blocking agent was chamomile, but that doesn't mean there aren't more. There easily could be several more. So
Chad asks, would CZ be the main hub to regulate that pattern?
Yeah. And anyone can chime in. I suspect that Saul can corroborate this quite strongly, but CZ is kind of a superior hub. And there's a lot of beta generators in the brain. You have like 4 alpha generators that are natural. Right. Maybe you have more that you don't want, but with beta you have more than 20, and there are inferior and superior hubs or nodes, and so the CZ generator is discussed as being the superior node for the other beta generator. So if you drive it down, even though it's also the orexin drive, it can take a lot of the other generators with it. There are exceptions, but that's why we post-train. We post-map and check, because I had a case recently where all the beta came down except for one corner. And it's like, sure enough, they had improvement in every symptom but one. And it was like, oh, it's over there. we got to put a sensor over there and go after it individually.
That's interesting.
Yeah, I thought so too. Yeah, I was like, oh, geez, that's cool. That explains why we got partial improvement, So, I mean, we can generate images out of this. I know we like to spend a lot of time in the raw because that's how we are. But I mean, look at that. El Chatterino had a really astute observation about the lateral. Now, this is actually worth mentioning. The phenotype low voltage fast is heavily associated with PTSD. It's also heavily associated with alcoholism, insomnia, and anxiety. But not every symptom is causal. Some of them could be correlation. So, for example, do we think that PTSD triggers this phenotype? Or do we think that families that struggle with alcoholism, to the tune of an average 80%, are they more likely to have, trauma? And I think that it's more correlation versus causation, that we have these alpha asymmetries at T6 are extraordinarily common with this phenotype. But it may not be inherent to the genetics. It might just be inherent to the family culture around passing down these genes 80% of the time. And then you end up with this right side asymmetry for alpha, quite easily, which is hypervigilance and reactivity commonly seen in PTSD and trauma.
I think Josh, the genes handed down sort of create like a very ripe environment to for stressors, let's say, or life stress. And then David Kaiser, he put up a chart one time showing the effect of a few drinks on the EEG. Yeah. And the crazy thing was, and I saved it, a few drinks completely normalizes T6 alpha.
Oh, really? Really? In PTSD as well?
I don't know. I don't know if he specified the diagnosis.
4 drinks will normalize the low voltage fast. I didn't know that it normalizes PTSD. That would make sense if it did, because you have a lot of PTSD people that drink.
It's like T6. From my recollection, I can actually try to pull it up. The biggest change was seen at T6, so I wouldn't doubt that it's helping with the low voltage fast as well.
Oh, wait, it's published. It's published that it normalizes. For example, alpha is a GABA agonist. Sorry, we misspoke. Alcohol is a GABA agonist, and you have this overgrowth of GABA receptors. And if you balance the relationship between GABA and GABA receptors, you'll get a brain with normal alpha and low beta. And so I think it's about 4 drinks for these low voltage fasts for you to see the shift where they start to look more normal with like lower beta and higher alpha. About 4 drinks is what it takes. And I'd love to look up David Kaiser's work. I can just reach out to him personally and ask him for it. He'll know me.
I have the Facebook post I'll send you now.
Yeah, that's great. Yeah, plus I can, if I can't find it, I'll just ask him personally. He's really connectable. So great.
Yeah.
Awesome. But that would make a ton of sense about it.
Exactly.
I've seen marijuana completely mask the T6 alpha. And
oh my gosh.
Sometimes I'll have them take a break from it just for like, I had one person who got stomach aches. This is not uncommon, so it's a very common thing I get a couple times a year. It's stomach aches if they don't use marijuana every 6 hours or something. And it's like, okay, I want you to do this. I want you to stop for 12 or 18 hours. And I want you to be a hurting unit, and we're going to come and redo the brain map. And sure enough, this alpha creeps up into a clinical range, into a neuromarker range.
As soon as they stop.
As soon as they stop. And that's like, long-term consistent use of THC has a half-life of 30 days. And so
that makes,
what you're seeing is not what draws. What you're seeing is just, what you're seeing is something more complicated than what draws. And you will see, as a clinic, a couple of those a year. They're not uncommon.
Well, something just came out that said that marijuana, a study in the last week, marijuana increases, or cannabis increases paranoia in people who experience childhood trauma. And so I've mentioned this for a while. I have multiple acquaintances who've told me they can no longer use it because now every time they use it, they get anxious. And so I think that there's a cumulative effect in at least some individuals, and they probably are the ones with, if I had to guess, with this T6 asymmetry signature here.
Yeah, I think Ryan or El Chadirino is saying that he's asking if it's part of Peniston's work. I know Peniston did a lot of work around alpha, and he had some really cool tricks to making these cases more responsive. Because you have cases like this, you're like, I don't know if I have enough alpha to train. But Peniston would actually have them do a finger monitor. You'd have to raise their peripheral blood flow by 1 or 2 degrees before they could do alpha training, because he's actually teaching them from more of a biofeedback standpoint how to get into a state that would then give them trainable alpha, which I thought was kind of a cool, brilliant shortcut to make back in the 60s and 70s. Was a really smart way to go about it. I feel like their work got integrated really late. Like it was like they were over on the addictions corner for too many decades, which bothered me.
Radar wants to know, how do you prove this in someone who is an alcoholic, since they pretty much always have alcohol in their system affecting their EEG?
Yeah, I mean, they'd have to come in drunk for you not to see it, so you're gonna see it. I mean, a lot of them, you could have a functional alcoholic who drank before they came in. We've seen it. Usually you can tell, though, when they're drunk enough to hide this, because it takes like 4 drinks. So I think it would be hard. I think it would be hard to hide it.
And we're seeing
Yeah.
Yeah.
We know that this radar, this is like one of the most genetically derived phenotypes is the GABA4 gene.
Yeah, it's a genotype. Yeah, it's not genetically influenced. It's genetically caused. It's a direct direct influence, direct effect, not influence. So
just one last thing, I just sent you the Kaiser post. He circles the change that happens to T6. And he says this is his sort of opinion. When you see this change, it reflects taking your life, in your own hands, having autonomy over your life. And that makes so much sense because it takes authority into own hands. Because there's a paper I have, I think it's an MIT paper that I have, but what it said is that T6 is the main barometer of effort in the brain. They call it like the thermostat. Yeah. So
brain barometer of effort.
And it kind of makes sense. I think, obviously, early life trauma is associated with a lot of dysfunction. And you could imagine some of that may be, things that might be easy for one person or it may not be for another. And it could be related to this phenotype and early life. Yeah.
So I'd like to understand that more from like a neurophysiology standpoint. Why do you think you could explain that statement? The main barometer for effort? Do you think you could?
I don't know yet, but I do think probably they tend to have hypersynchronized alpha.
Okay.
From the back to the front. I'm guessing it's around that.
Frontal lobes are associated with withdrawal and effort, withdrawal and advancement. That's a classic. I'm forgetting the main researcher because the name's on the tip of my tongue. There's a classic researcher that associated the left hemisphere with advancement and pursuit, and the right hemisphere with withdrawal. And if you have too much beta or too much alpha, which beta is activating, alpha is deactivating, you can actually look for clinical imbalances in withdrawal and advancement. And if you have a clinical imbalance in either too much beta or too much alpha, which will cause too excitement or too much idling, you can actually predict that somebody is going to be depressed or someone's going to be agitated depressed because you have too much advancement and not enough withdrawal. That'll be agitated depression.
That's interesting. So I'll save that approach avoidance behavior. Sorry. So I'll just read you. I have the paper and I sent it to you already, but this is literally what they said. They said right TPJ activity, which is the temporoparietal junction where T6 is, says our TPJ activity is inversely correlated with the match between willed action and the produced movement. So it seems to literally like maybe even compromise movement. It reminds me when Jay talks about frontal alpha and what is akinetic mutism, where people have such a profound lack of dopamine that they have trouble moving or speaking, he said. Anyway,
I'll have to read that really carefully. I wonder, do you think that's because of it's connected to the right insula and parasympathetic? Like I'm trying to fit that
Sounds
into
like
my
you
head.
already know more, yeah. Sorry for getting into the weeds, guys.
Maybe I'll call up Henry. It's not Henry, but David Kaiser, and I'll ask him to explain it to me.
Yeah. Saul, what's your take on all this?
No, I mean, Josh and Anthony know much more than I do about all this, but this is a similar.
I don't know about that, but yeah.
I mean, it's fine.
Yeah, I think you're being modest.
I get to learn a lot more. I get to learn. But the fast, low power pattern is when you were looking at it, it's thinking PTSD or alcoholism.
Yes. Yeah.
Wow.
Or both.
What kind of protocols are your favorite for these kinds of cases, Saul?
Well, I tend to start with stabilizing, so around either CZ or C3 minus C4, depending on the presentation and whether they can take it.
Yeah. So
and I do.
This case would definitely do well with this. I get really nervous if I see really, really fast alpha, and I'd love to hear your take on this because I'm undecided. I just get nervous when I hear people recommend SMR training and they have like 14 hertz alpha. Like, how do I do SMR when there's so much mu or so much alpha in C3, C4, or CZ? And I'm curious what your thoughts are on that, because that's not true about this case, but it can be true about low voltage fast. They can have a really fast alpha. Do you have an opinion on that? Because I'm kind of fishing for opinions and deciding.
It's just from just experience, for whatever that's worth. I tend to go at it very slowly and indirectly. So I may even do just inhibit, low and high inhibit at say C3 minus C4 or something like that, or even push a little bit frontally first.
Yeah. Okay.
I tend to
makes
go
me feel
front to
validated.
back.
Yeah.
So
So you have some of the
stuff you
same
just don't
maybe
wanna-
hesitations, but you are willing to
Yeah.
try. Okay.
Yeah. But
That's exactly what my
I'm
friend Alex Sanchez does, Saul. Just so you know, is if he's worried about the SMR, he'll inhibit the high and the low.
Yeah.
Because I think what we don't always recognize is that SMR training can be overly stimulating.
Yeah. Yep.
And some
it's
people
interesting
just
because it can
can't
be
really
both. It can be
tolerate it.
sedating and
Yeah.
stimulating, which is interesting. Yeah.
Especially when I see fast activity, I want to be a little careful trying to nudge up even low beta.
What's interesting, it's worth a try because SMR is found in research to be GABAergic, or GABAergic is the right phrasing. Sorry, GABAergic. And so you kind of want to try it, but SMR is tied to a lot of systems. I've heard some people who are smarter than me refer to it as like the brain's conductor, and so I don't know if that's true. I've just heard it referenced that way, and so like if that's true in at least some metaphorical way, that means it's tied to a lot of things. So like could it cause sedation? Yeah. Could it cause overarousal? Yeah. At least, you know, if they're describing that correctly. But it is shown to have like a counterbalance need for underarousal sometimes, and it is GABAergic, which means that it's a great protocol for low voltage fast if they're trainable with it. But it's also just like any client. You watch, and if they respond bad to it, you change it or stop. So if you get your hand slapped,
yeah.
We've all been there.
That was excellent.
Yeah. Radar gets back to the somebody that drinks that goes in for a reading, says their alpha will be lower than usual just because they are coming down from the alcohol.
That's interesting.
If someone is an alcoholic, doesn't mean there will be a rebound when they're not drunk? ?
Yeah, I wonder if that is a case of exacerbating the underlying pattern rather than like replacing it. But yeah, I guess maybe Radar, you could look at how they did the studies associating low voltage fast with the GABA4R gene variant. That's what it's called.
Yeah. GABA4R gene?
Yeah, I think because R for receptor.
Oh, okay. Yeah. That makes sense.
Yeah, I think that's the formal name. I can go find it for you.
I assume there was more than one gene that's responsible for this. I assume it's not just a single one, but like I think
it might literally be a single.
But I don't know. Because I think that there's stuff. Yeah. Anyways, I just had my hunch that that's what I was reading, or that's what I understood to read. I try to stay away from working with or taking on clients who are not in action stage of thinking. So if you don't know these stages of change predictions, which is a phenomenal thing to learn, even if you're a counselor, I highly recommend everybody learn it. It's learning just like what is the psychological process that people go through before they accept hard interpersonal change. And pre-contemplative is the stage where they're not thinking about how their behavior is associated to their own specific actions. My suffering and my choices, they're not thinking about how those are connected. The second stage is contemplative, where they are starting to think about how their behavior is associated with their own suffering. They're not blaming everybody else yet. Maybe they are, but they're entertaining that they might be choosing some of this. And then planning is where they're actually starting to daydream and talk about what they could do different. And then action is when they're ready to do it. And then other people have added things like a maintenance stage. The rule on stages of change is that you don't get to skip stages on large interpersonal changes. And the only way to speed up the stage that you're in is to do more of the stage that you're in. And acceptance and reduced enabling and codependency is the only thing that helps these people. And that's not a rule for addictions. That's just a rule for change. And it's just a coincidence that addictions has kind of co-opted this and made it theirs. Like counselors should be using this skill. It's incredibly useful in any kind of large interpersonal change. But if you have a client that comes in and they're not in action, and you offer them something really, really beautiful like neurofeedback, they are going to walk into your clinic in the midpoint of treatment, drunk, completely drunk, and you're probably going to fire them. They're not ready for it. Like, you shouldn't offer it to them until they're ready. And that's something that you have to caretake as the clinician. You have to actually like look at their history, talk to their family members, and and assess if they really are ready for this. Because I have my concerns about doing neurofeedback. Like, and this is something that Saul probably has more experience on than me, but I wonder if you do really, really good neurofeedback on somebody and then they go and they ruin it, is it going to be harder to train the second time?
I think it is, actually.
Yeah.
I do. I mean, again, I don't have the data, but
yeah,
my sense.
So yeah, there's no data. Yeah, I agree.
Yeah.
Wow.
So some of it's like common sense, like just being around, neurophysiology. We get the impression that could easily make it harder. The brain doesn't like to do things over and over and over again. It seems like that might be doing them a disservice by offering services too soon. So I'm very quick to turn people away. They need things to be really optimized and ready to go.
So when you turn them away, like what are you like? Are you smelling the booze, or you're seeing something on the scan? Like what's?
I want to know, and you guys can chime in too. But I want to know if they've been in any treatment programs. Are they part of any programs where they are, in some sort of accountability, or like AA? Are they part of any religious institutions? Have they? How long have they been sober? What does sober mean to them? There's so many questions, and then what is the family thing? I usually have like a group, and you'll find out really quickly that they're not ready. So.
Craig, somebody new to the show, I think. Fascinating.
Oh, that's Craig. I like Craig. I know Craig. Yeah.
Okay.
Awesome.
You're getting a shout out, Joshua Gents. Well done.
Yeah, Craig's a neurooptimal. I think he's the head.
Wow.
He's the head. I forget his title. I'm sorry. He's the head of something at Neurooptimal.
Craig, what's your title? Come on, let's give you a shout out. We'll send some. We'll send 3 people your way.
He's an incredibly generous and kind person, and he cares deeply, and he's very intelligent.
Oh.
So.
Well, it's a nice little crew that pops up at the top of Google when you put in neurofeedback, and Craig's company is one of them. Saul's company is one of them. Saul, when people are coming in to your clinic, what any of this stuff resonate? I represent the moms and dads that like the pretty colors and pictures to be taught what's going on. How do you explain it to the moms and dads when they look at that? Hopefully their kid isn't drunk off of that one, but
yeah. Well, no, I mean, I think I do a lot of what we've been talking about. Is I always start with the squiggly lines, and I always that's what I start when when I'm reviewing reports. I start with those, and I have Rusty Turner reviews my EEGs, and so I go through his report and I point out where the muse, particularly when we're working with kids. Well, here's mu, here's where ADHD is probably living, things like that. So I think it's incredibly important. And I also find, like, when I get reports from other people, if I just look at the report, I don't feel like I understand what's going on, and so I try to make my reports a little bit more comprehensive. So it's all about, what I tell people is, at the end of this report, 1, there should be no surprises because it's your brain, and 2, you should at least have a deeper understanding. Deeper understanding of yourself. Those are sort of my 2 goals, and of what we may do. So so you've got to talk about the EEG. With that.
I like that idea of when I'm reading their brain map, I want to be telling them things they already know. That's a great point.
So when I see, hold on, Craig's got a little bit more. Fancy pants gangster boy title.
Community educator coordinator. Yes. Love it.
Outstanding, Craig. Thanks for popping by.
I'm going to ask. This might not be entirely right. Get in touch with me, Craig.
Cool.
Interesting. All right.
Cool.
So when I show this to Jay Joshua, what should I do? Can I Can I just
do
take?
nothing. Jay will take the
he'll-
whole
yeah.
thing over and just go crazy. Yeah.
No, I was going to just give him like the worst parts of the recording.
Oh, really? Well, it's already cleaned. I mean, I kind of do all the work for you, you know.
Oh,
You know,
yeah.
when you have a low voltage fast, though, like, not that we want to do like 15 minutes of work in front of the show on de-artifacting, but that can be fun for some people. How do you de-artifact a low voltage fast? Very, very carefully, because they tend to produce more muscle tension, and it's high frequency behavior that's muscle content is going to be conflated with the high beta, because they have a high tendency towards insomnia, which confuses the fast Fourier transform mathematics. So you basically have to be super careful in the way that you clean these, because you'll want to it'll want to take out a lot of your fast content, and that's where all the energy in the brain is. And if you want to edit these objectively, that has good pre-post comparisons, you got to have a lot of skill. It's one of the harder ones to edit, to be blunt. So
Wow.
How long did it take you to edit it, Joshua?
Oh gosh, I did it years ago, maybe 2 years ago. I don't know. So
what I'm trying to do is somebody just gets in the field and they look at it. Obviously, you're going to use somebody to look over your shoulder, Rusty, Jay, Saul, whoever. But like over time, it's all about pattern recognition. How long does it take you to get that recognition?
Well, there's actually, I think there's a study on this that says that it takes 5 years for people to like be completely competent from mentoring. And like with experience in the field, it seems to get you see more consensus across like some challenge questions where we bring a case and say what's going on with the client. You start to get average normal answers without seemingly like chaos with about 5 years of experience, which is a bit discouraging. Okay, like, oh my gosh, so we just have people like doing nonsense for the first 5 years? And it's like, a little bit. It's kind of a bummer. So, you know, that's why I got into education, why I'm starting to build some coursework. It's like, okay, well, how do we actually get some of this stuff like foundationalized early on in a way that will shorten that from 5 years to maybe 2? And that's a bit of a dream. I don't know if it's possible, but I want to try. So, I feel that, like, I feel like it took me 5 years to find my feet. It's a little embarrassing, but it's true.
You think Gladwell, you know, is 10,000 hours? You think that plays in the neurofeedback, or you need more?
What's up,
Gladwell?
Malcolm Gladwell, the Outliers.
He says, like the Beatles, he gives the example that, you know, they played for 10,000 hours and they became great. Anybody that does something for 10,000 hours, I'm just spitballing here. How long do you think it takes to get to pattern recognition?
Yeah, that's so when I started doing brain mapping under Jay, I told him this recently, so I feel like it's okay to say it out loud. I dropped out of my doctorate. And I took the time I was putting into my doctorate into brain mapping. It was something like 8 to 12 hours a week. I read research, I looked at brainwaves, I consulted, and I did extra recordings, and I volunteered, and I just spent the 8 to 12 hours a week on brain mapping because I wanted to put the hours in. It was like, I can't do this an hour or two a week and expect it to get nailed down. But I directly dropped out of my doctorate because of Jay. I saw something of greater value, and I went for it. And I was like, I'm not willing to do this incredibly boring program where they're constantly asking me to give dumber answers than I want to give. I'm not happy with it. So versus I can chase something that is of great value. That's what I did. So I don't regret it at all. Not even a little bit. So
awesome.
Well, I guess the answer,
I think we're all lucky that you did.
Thank you.
Go on, Pete. Sorry.
Definitely.
Yeah, we're all benefiting.
Well, you don't get, it's not like 10,000 and you're an expert. It's just because you're never an expert, right? Because it's always
you'll never feel like one, Saul, right?
Yeah.
You'll never feel like one.
Well, doesn't Jay say if someone calls themselves an expert, run away?
Run, yeah. The sensation is a lot like homework. Like, you ever like something due on Friday and you're like, there's this homework. I always feel like something in your backpack, like it's a weight. And I always had that sensation when I was in school of like, oh, there's something due, it's coming up. It's like this wig in your brain that you can't let go of. Like, brain mapping feels like that all the time, forever. So like there's this awareness that I need to be more, I need to do more. And soon I've got to get my head wrapped around more pieces. And the longer you do it, the more blind spots you become aware of. But at some point, those blind spots become blind spots that everybody has. Like, there's not like somebody you go ask and they're going to just give you the answer like I've had for like the last 8 years. Eventually you're going to ask questions. Jay's going to be like, yeah, do the work. I asked him something on Monday and he was like, good observation. You're going to have to do the work on that one. It's like, oh, I didn't want that answer. I wanted a cheap answer. I wanted him to hand it to me.
Joshua, can you go back to the screen share and
sure, yeah.
like what? And I'd love to hear from Dr. Saul too.
Yeah.
When you explain what's going on, I know you want to go to the recording, but isn't it easier to explain the colors and, hey, you got this, and then point it to the squiggly lines? Or how do you explain it to somebody who doesn't know what's going on?
Yeah.
Well, I might point out the general fast, the high speed. Most people aren't really going to understand the low voltage as much, but they'll understand fast, and it will make sense to them because they're not sleeping or they're anxious or both. And and then I could say, now, the way that I explain the spectra is that each little square, each graph is a different sensor, and along the horizontal, it's frequency, and vertical is power. What I usually say to people is it's like if you think of each EEG line as a phrase of music, I'm going to break it down to the individual notes and how many times those notes are played. And that people understand that, or how loud the notes are.
Yeah, I like that.
And what we, for the typical brain, it shows a particular pattern. Your brain's not typical. Doesn't mean it's good, doesn't mean it's bad, it's just not typical. Now, where is that connected to your symptoms? That's where we want to train.
I like that.
Yeah. Yeah. I typically think of the maps as being demonstrative.
Yeah.
Not evaluative. Now, sometimes they clue you into something you missed and you can go back in the raw data and look for it. But if you miss step 1 and step 2 helps you out, then you go back to step 1 and you validate. And that's what was always missing, like how many different types of theta are there? Too many. There's like 7 or 8. Only one is healthy, but there's a lot of different types. Sometimes it's just slow alpha. Sometimes it's tonic theta. Sometimes it's focus slowing or instability.
The pretty heads, Joshua. Are you going to? You don't show them the pretty little heads and the.
Yeah. I mean, I can show them the pretty little heads, but that's after I've already validated what they are.
Okay.
And so, if I see, I think it was Yuri Kropotov who posted how, basically here's the types of theta that are genuine and real. You've got frontal midline pulsed theta. It's usually a memory function. You've got vigilance theta at CZ. That's it. He's like, that's all. Everything else is dysfunctional. You're like, oh, okay. Oh dear.
Was that Kropotov you said? I don't hear much about this vigilance theta. That's very interesting.
You get drowsiness. People start producing theta. Yeah.
Oh, got it. Okay. Yeah,
that's B1, B2, B2 drowsy, B3. Nothing crazy. And you can get even some alpha might slow down a little bit into the theta band in some cases, but it's vigilance related in those cases. So you have theta propagated by vigilance, theta as a memory function that is very short bursting, not long, in the anterior cingulate, and that's it. Everything else is dysfunctional. Now, everyone's got some because we're humans and we're all slowly aging. but when you have a lot of theta at F7, it's like, okay, what is that exactly? What is that content? What is that theta content exactly? And there's different names for how it looks in the raw data. Different descriptive, ways to identify it. And the ways that it's described can have different implications. So, yeah.
I think, and now at the same time, you're probably not going to run into trouble suppressing, you can't really suppress the good intermittent theta. to my knowledge. So if you
I would
suppress
try.
phenolphthalein,
Right.
I don't want to find out that you can.
yeah, but who really? I guess I would say, like for instance, I don't think I've seen a map from the practitioners I trust that they're not suppressing theta along with the rest of the slow frontally.
I don't
You know what I
that it's
mean?
bad
Like,
to train down, vigilance related theta. I don't know that you're going to be successful though. I just think it's not going to work. That's
yeah.
why we saw all the theta beta ratio studies fail out in the year 2000s, because we all got drowsy.
The other thing, so that one you'll allow to be trained out too, you said, or no? Sorry.
Well, I mean, I wouldn't want it to be the main protocol because everyone's got such poor vigilance these days. And the research Martijn Arns did kind of clarified what was going on in that case. It's really vigilance related. We sleep 2 hours less than we did 30 years ago, and that destroyed our theta to beta ratio protocols. Absolutely destroyed them.
Well, I guess because Saul had mentioned that he will do, and as I said, my friend Alex does, for people who they're worried about SMR with, they will just suppress the slow and the fast. And I'm wondering, does Saul see his patients getting drowsier if he's... It's not something I've come across, let's say, if suppressing that theta at CZ.
It can happen. Yeah.
Okay.
So you just need be careful. I mean, up here, everybody has sleep deprivation.
Yeah.
I know.
My people when I do eyes closed record, I do the eyes closed recording first because people will be falling asleep during it. And so I want to get that out of the way.
Here's something else though, Josh, as I've mentioned before on this podcast, they found that your level of task-related theta, like that good intermittent kind, it's inversely proportional to your level of resting theta. And so in my mind, I think that makes it even less likely you can go wrong by getting rid of theta up front.
Yeah, that makes so much sense.
In fact, that's true.
I mean, I'm thinking right now, and I'm remembering, Jay's addiction study, 30 subjects, he did about 3 things, but a lot of them just had, not just. One of the things he was doing was he was suppressing the fast and the slow frontally, and they gained 20, 30 IQ points. Yeah. Like, or cognitive exams, they're very related, or they're correlated.
Was like extremely holistic. That was incredible. Yeah.
Yeah, and he did 3 things. He did SMR, he did frontal suppression, and he treated the low voltage fast, I think.
He sorted them by phenotype, whether it was low voltage fast or frontal lobe disturbed, and he treated them based off of their phenotype. So it was a mixed phenotype study. I remember that one. And that one was like, he did a lot of different assessments. Supposedly, I didn't see it when I read the study, which confused me, but he talks about it as though he did a long-term follow-up, and he was able to have a lot more data on how they improved and enhanced on follow-up. But I didn't see that in the publication. I wonder if there's another version of the study out there that I missed.
I've seen it happen to friends that I see them and I just feel like they're getting smarter every day. It's a little crazy,
I know.
It's a subtle thing. It's subtle, but I think it's there. Real quick, one other thing I was spitballing with, by the way, Dr. Saul, Craig, maybe you want to tell him how he could get in touch with you, because I think there was a little confusion there. How you prefer,
Sure. Email is fine. If you just Google me, you'll find my website or email or something like that. Or I can get in touch with him,
and I'll find it for him and send it to you. Yeah, I'll track him down for you if you have trouble with Craig.
Yeah, just wanted to make sure. He thought you were me for a second, so that's why I wanted to step in there. Yeah.
So we're getting to the end of the show. The last call. The lights are on. What are we doing to help this person with this issue that we see here?
This case. So again, Saul mentioned doing some SMR protocols, which you still want to watch closely. And I agree that that's a really great protocol, especially with somebody who doesn't present with fast alpha. That's usually very, very safe. GABAergic approach that will help offset the excessive growth of the receptor growth. Though the research, if you don't both suppress high beta and train up alpha, you're not going to get all their complaints. There's actually a study that shows like an improvement in, anxiety, but not sleep. And that's when they trained up one, but not the other, or something like that. There's all kinds of interesting variants out there of research where, if we just train down high beta, not alpha up, we get some improvements, but not all. And you get the most holistic approach is going to be trying to get SMR if you can, trying to train down high beta centrally and locally if you have to. But you try it centrally first, and then if you have enough alpha to train, or when you have enough alpha to train, you train alpha up. And you can do alpha theta. That's been researched, as someone mentioned, by Peniston. That's absolutely true. Again, it's all based on whether you or not you have enough to train. So you got to have something to train it. And this case has some, but it's a little bit of a hard catch because they're not high above the noise, but it might work. I'd be more comfortable if there was a little bit more.
And your cutoff for that is what, would you say? Or
I'm not a numbers guy. I'm looking at it more relative to what the actual noise looks like and how much artifacts they're prone to, and whether or not I can evidently see something that is going to be reasonable compared to basically like the noise ratio. Like, is this feedback loop going to be accurate or vague? And so you're thinking about it more dynamically, like, are they prone to a lot of fidgeting and muscle movement? Sometimes you turn off. I don't want to save this, but you can just turn off the de-artifacting and just see how bad was it. And the answer is not bad. As long as they've got some alpha periodically at PZ, and they do, but it isn't a lot. With this case, I would probably train down high beta for a while first. I'd probably do 10, 12, maybe 15 sessions at most, high beta down, and then add in alpha up training along the way.
Would you train alpha in the back, like at PZ or P3?
Oh yeah, absolutely. Yeah, it'd be PZ probably. Some people do something more fancy, but I don't think it really matters with alpha. Alpha's a really, really self-oriented mechanism.
This is cool.
As long as you catch it.
Oh, I see. Okay, there it is.
You can see what's there, by the way, by going to like analysis and band ranges, and you can just switch this to default and go to alpha and just see how much alpha is really there. And now I'm only looking at alpha. Okay, I've just like removed everything that's not alpha, and there's just not much there at PZ. Like think about how big the noise was relative to what we're looking at now.
Yeah.
I don't really feel like training it up at T6. That's the trauma neuromarker. I need to train it up centrally. And I don't have a lot to work with in this case, which is why I would do high beta down. Free up a lot of metabolic activity. You think about this, 30 hertz alpha, sorry, 30 hertz, maybe alpha, 30 hertz high beta has 4 times as much energy per amp for those microvolts. So I get 4 times the size of alpha when I train down a 30 hertz finding. And that's because when you double the hertz, you are working with half as much microvolts with the same amount of energy.
Right.
And if you go to 30 hertz,
it's incredible.
It's 4 times as much. And if you go to 40 hertz, it's 8 times as much. It goes up double every time you double the frequency. There's a lot of energy in beta that can be freed up to give you more alpha. And you'll see that after you suppress high beta successfully, that there's just more alpha hanging around now and you can train it easier. So
do you ever see that happen with SMR? Because that is when you suppress. Oh, good. Okay, good.
So you will see it with SMR just because SMR is GABAergic, and even though you're not training down high beta, and there's no reason if you have software that can do inhibits and rewards, which I have software that has separated inhibits and rewards. I like that a lot. I'm going to train down high beta at the same time that I train up SMR because I have no reason not to, because my inhibits and rewards are separated. And so why wouldn't I just do high beta down at CZ while I'm there? Or, there's no reason not to. But
I'm thinking of those patients that you're worried about doing the SMR with. Yeah, go on.
Yeah, even if all I was doing was SMR would start to drive down beta a little bit because it's GABAergic, and beta is driven up by excessive balance in GABA to the receptors. So you're kind of reducing that relative imbalance by adding more GABA into the system with SMR, and that's why.
But you don't see it happen. You don't see it happen in the reverse where you get rid of the beta and the SMR comes up now.
I think everything comes up when you get rid of the beta. I think you just end up increasing.
Oh, that's good news.
It's like you're increasing the water pressure in the house. It's just like everything gets more.
I like that. I learned 2 good metaphors today.
For better and worse, but they don't feel worse because they get more theta or they get more instabilities. They just look worse. They don't feel worse. So they'll just get louder. Generally, these maps can be unstable. Like it's very hard to be stable with no alpha. So if you see instabilities in a low voltage fast, don't freak out. If there's a little bit of it, those kind of wash out when you give them alpha. I don't know why. It's smarter than me to explain that.
This is very cool.
Well, Joshua, thanks for putting this up on the screen here. The brain bar was something that was suggested for us to do. We're giving it a shot.
Sure.
Love to hear everybody's feedback on this. We're going to take this, work with Jay Gunkelman. He's going to look at this fresh, and he's going to do his parlor tricks. And what I'll try and do is connect this Q&A with what Jay does, so that way, because there might be a couple weeks. but I'll connect them together. I'd love to get everybody's feedback if that's working out, if we should continue doing it. The panelists, thank you, Dr. Saul Rosenthal. All your details, I put your link in here. We'll have it on the details as well. When I make the thumbnail for this, Joshua Moore, we'll put you up there, and Anthony Ramos. Hey, guys, thank you so much. And all the new people that came in. We had Craig coming in. Radar came back as well, a regular. We know his favorite drink. And, of course, El Chatterino. Thanks for stopping by. Everybody, have a great night. You don't have to go home, but you just can't stay here at the Brain Bar. Take care, all.
Hey, Pete, I want to give you a shout out real quick because I think it's great the idea you had to do this. Obviously, love that Josh is spearheading the analysis, but yeah, I was thinking right before you did this, I was saying, how could we get more practitioners on the same page? And I think this is like the number one way that anybody could have thought of right now to do that. So thank you.
Well, awesome. This is a team effort, and we'll do this, and then whatever it takes to get somebody to consume the information we're willing to do here. Everybody, have a great night. Take care. Much appreciated, all. Stream is now.
Thank you, guys.
Bye-bye.
Thank you, everybody.